Welcome back, everyone, to the Breast Cancer Podcast, as well as the Breast Podcast Ever. I have the famous Dr. Tiwari with me, and this is the Breast Plastic Surgery Educational Series. And today we're very lucky to have Jodi Deistler, physical therapist, and she was on the breast cancer podcast in the past, and it's one of the most downloaded podcasts. People just want to know about physical therapy after breast cancer diagnosis, all the different things that go with the breast cancer diagnosis, including lymphedema. But I want you to introduce yourself, Jodi, because I don't think I'm going to do justice to what all things you do.
Well, it's nice to be here. Yes, my name is Jodi Deistler, and I'm a physical therapist by trade. I've been treating for about going on 33 years now, so I've been out and around a long time, and I've been the Revital Oncology Program Director for almost the last 2 years. Really specializing in oncology in the last 14 or 15 years, really because, oncology rehab is not the standard of care yet. When we see surgeries like a knee replacement, then physical therapy is the standard of care. Nobody would ever have a knee replacement and not have physical therapy because they've got, an area that's been opened up, things have been removed, new things have been put in, they have scar tissue, loss of motion, you've got to work on getting back their gait. You would never see someone not referred for that, but in the oncology world, cancer rehab is relatively new, really, over the last 10 years, and it's not the standard of care yet. With 60 to 90% of people that have some sort of problem afterwards, there's a huge need. So really, that's my job, is to get the word out that this is something that is going to help improve patients' quality of life, get people back doing everything they were doing prior to surgery, prior to any of their treatment.
Yeah, I'm very excited to talk to you, Jodi, because we've not met before formally, and we get questions all the time about physical therapy and rehabilitation. So from a reconstructive standpoint, I think we're going to learn a lot.
Yep. So, just to tell you a little bit about what cancer rehab is, because it's probably the most common thing I get in the office. People are referred in, they're like, what exactly are you going to do to me? They know if they have an ankle sprain or a shoulder surgery, they kind of know what we're going to do in the office, but oncology rehab is a little bit foreign to most people. So I usually explain it as, the surgeons, the medical oncologists, the radiation oncologists, they're taking care of getting rid of the cancer, but there are lots of side effects to the cancer itself, to the surgery, to the chemo, to the radiation, even to the medications. Things like scar tissue, loss of motion, loss of strength, pain, cancer-related fatigue, lymphedema. All of those things come into play, and that's really what we're doing in cancer rehab. I always like to say, anything you were doing before your diagnosis, we want you to be able to do after we're done with all the treatment.
Jodi, I did want to ask you, there's a new term called prehab. This is, I think, like it's come up like in the last 3 to 4 years, I think. And, I've been doing this for 10 years, and I haven't really heard this early on in my career. And what is prehab? How do you explain that?
Yeah, prehab is seeing a patient before their first big event. And prehab in the physical therapy world has been around a long time. We've seen people prior to hip replacements or knee replacements or rotator cuff repairs prior to surgery. And we do that in the oncology world too. So when someone comes in for a prehab appointment and they're maybe going to have a lumpectomy or a mastectomy, we're going to get baseline measurements, we're going to assess for impairments, and then most important, we're going to do a lot of education. And that's all dependent on what type of surgery they're having. All right, yes, so prehab is seeing patients before their first big event, whether that's chemotherapy or surgery. And we bring patients in and we do a lot of baseline measurements, things like hand grip strength. It gives us a global strength measurement that we can measure throughout as we're doing prospective surveillance, or a timed up and go. It looks at their balance. We might check their girth measurements so we know what they are prior to surgery, after to surgery. And most importantly, we do a lot of education on this time. So we have a prehab booklet that we use, and we go through things like, what is cancer rehab? Because as I said, that's sort of a confusing thing for patients. We talk about, what is lymphedema? What would put you at higher risk? What would put you at lower risk? What's cancer-related fatigue? What about shoulder mobility? And then we get them started on exercises and a walking program so that they're really ready for surgery or chemotherapy, whichever is their first big event. Now that can be a little different in the reconstruction world. We do prehab for, say, a deep flap surgery, and that's a lot different because that's a really big surgery and it's really two surgeries. We have a breast incision, we have abdominal incision. So what we do in that prehab is actually a little bit different because we've got to get people's legs moving, their core, their glutes, their low back, and flexibility is huge because if you think about that big surgery, when people come out and they have incisions on their chest and their belly, they want to flex forward a little bit. And all those hip flexor muscles get really tight. Gait starts to be shortened, and then that leads to low back pain. So we do a lot of education on posture and body mechanics and really getting patients ready so that, it's a long journey on recovery, whether they're recovering from a mastectomy or from a deep flap surgery or implant surgery. So I always feel like the more we can arm someone with knowledge, with exercise to get their body ready so that they know what to do when the surgery comes around and they have it and they're recovering.
I love this. So a couple things jump out at me. So when would you start a prehab protocol? Let's say someone's going to go through a mastectomy, deep flap reconstruction. Are we talking about a week? Are we talking about a month? Are we talking about 3 months?
Yep, that's a good question. So we typically have protocols with different offices. So like with Dr. Halaharvi's office, we've talked to all the surgeons and said, what would you like? How should we set this up? So in their office, we see people about 3 weeks out. Once their drains are out, if they've had a mastectomy or if they've had a lumpectomy, it's still around 3 weeks out. And then we get started slowly on things, slowly restoring shoulder mobility, getting patients back walking slowly, doing easy things like diaphragmatic breathing, and just really, getting back to normal life is what we're doing. And that's really individual based on who comes in. If I have someone who's a nurse and, they've got to be able to get back to being a floor nurse, there's different things that I'm going to work on versus somebody who's retired, but maybe they watch their grandkids and they've got to be able to lift them. And, how's going to be the best way to do that? And when is it safe to do that? Now, in your office, we see people more like 3 to 4 weeks out, and that's what we've worked out with your group. And then we just slowly start some of the same things. Diaphragmatic breathing, almost always one of the first thing we start. Pelvic floor strengthening, because when those abdominals aren't allowed to work for quite a while, we sometimes see some pelvic floor weakness. And then slowly restore their mobility, whether that's their hip flexibility or getting shoulders moving again.
I like that. Would you say, in your experience, that someone's preoperative fitness level makes a big difference for them post-operatively in how they recover? Or do you think it's not that correlated? I don't really know how I feel about that because I feel like it's a bit across the board.
Well, it's funny you bring that up because, what I found is sometimes people that are in really good shape think they don't need the prehab. But most all of us do, really. And I always say whether you're in really great shape, somewhere in the middle, or you're a couch potato, you still need that prehab because most people can't recover from something without some direction. And that includes me. I've been treating 33 years and I had a hamstring strain in March. And it's probably not a great idea for me to treat myself because your wants and your needs are at war when you're treating yourself. So most people need some direction on how much to do. In fact, the biggest problem I'll see is patients will come in and they really weren't sure what to do, so they didn't do anything. So you get people that maybe overdo it, but then more often than not, I get the opposite where they were like, well, they said I should do a little bit of movement, but not too much. And so I wasn't sure what to do. And so I didn't do anything. So I think most people, doesn't matter what your fitness level is, you need to come in for those appointments. And of course, the better shape you are in, I think usually the better you are coming out.
It is a tough one because you want people to be active, but there are people that can be too active. You want people to be mindful of, how they're doing things, but it's hard to titrate your activity without some real guidelines. And I like the fact that you're able to give patients guidelines.
Yeah, I think it's really important to have, a team working together. I think, we have to be communicating with you guys and with the patients so that everybody's on the same page. We're giving consistent messaging on when things are allowed in regards to lifting and pushing and pulling and when they can lay flat in bed and when they need to stay in a recliner. I think that consistent messaging is just really important.
I agree. There's patients who are not very active before the treatment, and there's patients that are super active before the treatment. And there are patients who want to become super active so they can get back. And so there's all different levels of activity that people are at. And at the basic, some people are not used to walking. and just, used to sitting all the time. And for them, maybe just getting up and walking, maybe, that's what they need to start doing. Someone who may be an athlete, and for them, requirements may be a little bit different. Do you agree with that?
Yeah, I think so. I mean, and that really highlights why we need to see them prehab, and the sooner the better, because, people that weren't moving at all, we can even get them, even if we're getting in 3 10-minute walks a week, that's better than no movement at all when they haven't been doing anything at all. And for the people that are already doing a walking program, we just talk about how to modify it and what you can do afterwards. Obviously a few days after surgery, we're not having them out walking, but but we want to give that instruction on when that's going to be possible, and that it is possible to do everything afterwards when the time allows, that you're doing prior. It's probably the biggest thing patients ask me, I'm a runner now, am I going to be able to be a runner afterwards? I'm taking care of my kids now, am I going to be able to do that afterwards? And the answer to that is always yes. That is always my goal. Whatever you were doing prior, I want you to be able to do afterwards.
Yeah, in my experience, I do think that patients return to whatever activities they enjoy doing, but it is a process to get there. And I
Yep.
think that the rehab piece is very important. Maybe can you take us through some specific exercises that you have either breast mastectomy patients do or combined deep flap patients do?
Yeah. Let's see. I'll start with deep flap. When patient comes back from deep flap, the first thing we're starting with is that nice diaphragmatic breathing and some shoulder mobility. Just within pain, where pain allows. So we might have them laying down, doing some nice overhead work. A lot of times we'll do things on their side. We call them an open book stretch. You might have your arms closed like you're a closed book, and you're opening up across, so you're getting a nice stretch across there. Once we get 6 to 8 weeks out, we start some scar massage, especially after a deep flap. There's a lot of scarring, a lot of work we can do to make it more comfortable for people to move. And just after breast surgery itself, we do a lot of scapular and postural work. Everybody wants to come in really forward flex. So working these posterior muscles, there's been no surgery done back there, so there's nothing contraindicating us to doing things like shoulder blade squeezes, even some neck retraction, some neck mobility. Some of those simple things really start loosening people up where they're feeling a lot better.
I do think surgery definitely complicates things, but we're so used to looking at our phones all day or looking at a computer. Our posture really does impact our posture. I do tell patients to make sure they're doing some exercises that involve some strength training of the chest, as well as the forward and the back, because that does play a huge role in recovery. And I think one of the things you have touched on is diaphragmatic breathing, right? And that is something we are not doing a good job of breathing, taking deep breaths, right? That calms down your nervous system. It activates the parasympathetic nervous system, which is what we need to calm down in stressful situations. So when I do have patients come in with new diagnosis of cancer, I'm listening to their lungs and making sure they're taking a few deep breaths, and that does seem to calm them down. Do you have any particular techniques on breathing, inhaling, exhaling? Do you have a ratio on that?
Yeah, I usually have people lay supine with their knees bent, and I usually have them put one hand on their chest and one on their belly. So I always say, if you're running across the parking lot, you're going to be breathing quickly through your chest. But when you slow that breathing down, you should feel your chest stay still, and you should feel your belly really expand when you breathe in and really pull it back in when you let that air out. So I usually tell them about a 5-second breathe in, about a 5-second breathe out. And I usually have them do it about 10 times. And, I find it's really good for a couple things. Number one, the night before surgery, when you're thinking about surgery and you're worrying, if you hit 10 or 15 of those, boy, you're going to be right to sleep. But also the day after surgery, when you have a little bit of pain, maybe some anxiety, you slow that breathing down, and that really is helpful. And it's also good for your lymphatic system. So, I'm usually teaching it because it's good for the lymphatic system, but there's lots of other side benefits. So I always say that's the easiest exercise I'm going to give you, but it's really one of the most important ones, because it can, address a lot of different things.
This is something that I would love to ask, where we have a lot of obviously implant patients who've undergone mastectomy. A very, very common complaint is shortness of breath. And I've always felt that the shortness of breath also relates to anxiety and kind of more psychosocial, emotional, mental consequences from this mechanical problem. So it's really interesting to hear you say that because I've kind of felt this mind-body connection with
Mhm.
breathing and implants, and I've noticed it for years.
Yeah, well, and it's amazing. I usually tell people to do it 3 times a day. But if you take 3 concerted times a day to slow things down, that makes a big difference in your whole day. Yeah.
Yeah, that is such a useful tip, Jody, for our listeners, of our audience, to making sure they're taking time to take deep breaths. And we are such a fast-paced society. We are on the run, from one thing to the next thing to the next. I mean, I'm guilty. I'm sure Dr. Tiwari is too. We're taking care of patients, taking care of the office situation. So we sometimes forget to breathe, but that's a really great tip. Thank you for that. It not only helps you to calm yourself down, your nervous system, and mindfulness, really essentially what that is just focusing on breathing, and that has so many positive impacts on different areas of our life in general. So
Yeah.
what are some complications that you see if patients don't come to prehab or rehab, or uh, what could you tell our listeners?
Yeah, I mean, the number one thing if we don't see people after deep flap is low back pain. And if you think about it, it makes sense. You have this big abdominal incision, these big chest wall incisions, and you're forward flexed a little bit. Your hip flexors get tight. You're in that slightly flexed over position. And if you don't restore that mobility, people will end up with back pain. So that's the number one thing I will see down the road when people haven't had a little guidance on improving that hip flexibility afterwards. The other thing I'll see a lot is pelvic floor issues. If they haven't worked on those abdominal muscles, it's usually 6 to 8 weeks when we're starting that mild abdominal work. And I think 3 months usually for your office, Dr. Tiwari, before they want us to do too much heavy duty abdominals. But that, 3 months is a long time for those abdominals not to work. And so many times people will start to develop some pelvic floor issues. The other thing is shoulder. After just regular mastectomy or lumpectomy, if they don't have that instruction on moving, then usually they end up with about 150 degrees of flexion instead of that full 180, because most of our day we can kind of work in this area. You don't really have to reach all the way overhead until you're reaching in the back seat to get something out, or you're getting something off the top shelf. And so sometimes patients will come and say, well, this is just as good as it's going to get. And that's when I say, no, this is not as good as it's going to get. We can get full mobility back. But people need that direction, because sometimes it hurts to stretch that last 10 or 15 degrees, and they're a little bit nervous. Is this going to, am I going to tear something open? Am I going to hurt anything by doing this? And certainly when they're 3 and 4 and 5 months out, there's no risk at all to stretching all the way. So those are the biggest complications I see if people don't have a little bit of direction. And, it just goes back to, we want everyone to have a good quality of life. There's no reason for people not to be able to do everything they want to do.
Yeah, I really want to echo that because I think most people, like you alluded to before, are worried about hurting something, doing too
Mm-hmm.
much, tearing something. Particularly when we're after 6 weeks, it's basically impossible to quote unquote tear something or cause a problem. So really at 6 weeks, I want you getting back to as much activity as you possibly can.
So I know we are talking a lot about the exercises for lymphedema, things like that. I just kind of want to take a step back and kind of talk about what is lymphedema, how does that happen for patients, because some people may not know what lymphedema is. And so our body, we have lymphatic fluid in our body, 2 to 4 liters gets cleared by this lymphatic system. And there's about 5 to 600 lymph nodes in the neck, underneath the arm, groin, stomach, all in the tailbone, different areas. And the purpose of the fluid is it removes the bacteria, removes the waste, and it goes into the ducts, thoracic duct, and into the venous system. It gets cleared. So that's the purpose of lymphatic system. So in terms of the breast surgery, as a breast surgeon, when I'm seeing patients, whether they have a sentinel lymph node biopsy or an axillary lymph node dissection, so the difference being a sentinel lymph node biopsy is essentially removing this couple of lymph nodes that are first draining lymph nodes. A lymph node dissection means you're removing 10 or more lymph nodes, because there's cancer involving the lymph nodes. And thankfully, the studies have shown we don't have to do lymph node dissection as often these days as we were doing 10, 20 years ago. And studies have shown people who will get lymphedema, it happens, from the time of their surgery up to 30, up to 3 years. So 80 to 90% of the people develop lymphedema within the first few years. And so we do have informed discussion when they come to the office. A sentinel lymph node biopsy puts someone at risk of developing lymphedema by 10% or so. And then after a lymph node dissection, it could go up to 30%, especially if it is combined with radiation. And so I think those things are important for our listeners to know as well. Is there anything else you would like to add, Jodi?
You know what I usually tell people in the clinic are there's sort of 5 things that put you at higher risk for lymphedema. Just what you talked about, having more lymph nodes removed. If you have radiation, you're going to be at a little higher risk. If you have a higher BMI, you're going to be at a little higher risk. If you get an infection after surgery, or if you're on one of the taxane medications, chemotherapy medications, and that's sort of a new risk factor just in the last few years that they've learned about. So those 5 things put you at a little higher risk. And really, research shows there's only 2 things that decrease your risk. One is knowing about it so that you could recognize it. And, you know, that is just knowing things like, gosh, my arm's feeling a little heavy. It's feeling a little full. Maybe when I bend my elbow, it feels tight. My rings feel tight. My wrist feels tight. Those are those first early warning signs. Of course, now in most offices, they do SOZO measurements, so that's catching things early. And, you know, the number 2 thing that helps reduce your risk is early range of motion. The people that used to walk in the office with their arm kind of over their chest, kind of holding it in, those people are a lot more risk for lymphedema than the people that start moving a little bit more early. But number 1 thing is knowing about it so that you recognize it early, because there's 4 stages. Stage 0 and 1 are reversible. And so, of course, that's when we want to catch it. We don't want to catch it in the chronic stages. In those higher stages. And really, in the office, I almost never see people in those higher stages anymore because people are really watching for it earlier and they're catching it in that stage 0 and 1. And the protocol for that is getting them in a compression sleeve for about 28 days to assist that system. I always kind of tell patients, think of it like an ankle brace. When you sprain your ankle, we put an ankle brace on just while that area is healing, but we don't want to wear that ankle brace forever. We want to get that off because we want your muscles to still work. It's the same thing when we're in stage 0 and 1. You want to get that compression on just during that time when things are getting back to where they should be, but not any longer, because ultimately we want your body to do the work. So, you know, early stage, we're doing some compression. A lot of times we're teaching self-lymphatic massage because that can help, and then exercise, because those are the 3 things that research shows will help lymphedema. Moving the fluid, keeping it out with the compression, and then backing that up with some exercise. And all 3 of those are pretty important. So we try not to leave any of those out.
I really like that early mobilization piece. You know, that's not something I was aware of, but that actually decreases your chance of lymphedema. And
Yep.
lymphedema is very difficult to treat surgically. You know, we have stopped addressing it in our practice as a surgical problem. We do work with Dr. Joe Diane in New York City for some of the surgical issues, but I think the vast majority of these can be addressed in exactly the way that you're saying, which is early mobilization and really being aware of it. I think the awareness is key.
Dr. Tiwari, I know you're touched on surgery, and for listeners who are not aware of the surgical options for lymphedema, it would be a lymph node transfer or lymphovenous bypass. Is that what you're referring to?
Yes, that's essentially the 2 surgical management techniques. I think lymphovenous bypass has supplanted lymph node transfer. I think lymph node transfer has some problems associated with it. Mainly, you're taking lymph nodes from another location. For the patients that are further stage that Jodi was referring to, those 3 and 4 stages, we'll do liposuction. That is helpful to debulk some of that almost fatty infiltration for chronic lymphedema, but it doesn't reverse the lymphedema. The best way to deal with it is to address it early on. And as soon as it becomes a problem, I think mobilization is key, compression is key. Seeing Jodi and her team are really important.
Yeah. And as breast surgeons, I will tell you, like when we are doing a lymph node dissection, meaning removing a lot of lymph nodes because there's involvement of cancer in the lymph nodes, what we do is reverse lymphatic mapping. And essentially what that is, we inject a dye, it's a blue dye, into the upper arm, and it goes through the lymphatic channels. So we preserve any of those lymphatic channels, especially if it's not involving the lymph nodes. And studies have shown that does decrease the risk of developing lymphedema. So we have been doing that routinely. And also, I mean, we just don't do as many lymph node dissections these days. Thankfully, that has been a good progress in the breast cancer world.
Yeah, I think that's
There are
a huge
some.
part of it is doing more sentinel lymph node biopsies versus actual lymph node dissection, being really careful with patients that need radiation treatment. Do you see, out of curiosity, do you see lymphedema in the breast conservation people who maybe have not had a lymph node dissection, but of course have had radiation?
Yes, so I have seen you. Are you talking about lymphedema in the breast as opposed to the arm?
I'm talking about
Or
the
you
arm, but I'm a little bit curious about both.
Yeah, so the times that I have seen lymphedema is the times where patients have had a lymph node dissection associated with radiation. And also, like Jodi mentioned, the taxanes, anthracyclines can also cause lymphedema. You mentioned in obesity is a risk factor, radiation, chemo, also being elderly, and that's a risk factor. And also any injuries to your arm, that's a risk factor for developing lymphedema. I've not really seen a whole lot just in the setting of a lumpectomy or breast conservation or what we call a partial mastectomy with sentinel lymph node biopsy. The most times I have seen is in the setting of a lymph node dissection associated with radiation. I have seen lymphedema in the breast, not very much, maybe just a couple of times. But do you see patients for that, Jodi, for lymphedema in the breast?
We do, and it varies whether it's someone who's had a mastectomy or deep flap surgery or a lumpectomy, but we do occasionally see it. We don't see it as often because a lot of those lymph nodes are in the trunk, so you're closer to other lymph nodes. Down the extremities is much harder, whether it's the legs or the arms, but we do see it. We do see it, and usually the treatment is a compression bra. We can use things called swell spots, which puts a little extra pressure. Just because of gravity, most of the time breast swelling is in that inferior lateral area, and that's, as I said, just because gravity pulls it down there. So we put an extra little bit of pressure in that area with the compression bra, and it usually takes care of it. And then working the chest, doing some opening exercises, some chest wall stretching, a little bit of TheraBand, getting those muscles pumping usually takes care of it pretty quickly.
I think that's a real take-home message for me in this conversation today, that particularly for lymphedema, having patients think about exercise and think about just movement, which kind of it just makes sense to mobilize some of the fluid to reduce the chances for lymphedema. One area that I think is a real problem is this kind of upper arm lymphedema. I don't know if you see that among patients. I'm wondering if that is affected by doing TheraBand, by doing some of these mobility exercises that you're referring to.
Yeah, I mean, if you took a picture of 10 people with lymphedema, it's going to look different on everybody. Somebody, might have it mainly in the dorsum of their hand or their wrist. I get people that mainly have it in the upper arm, mainly in the elbow. So it really presents differently on everyone. It's not really a one size all how it looks. I've seen a little bit different presentation on a lot of different people, but regardless, the treatment is the same. We've got to get the fluid out with some sort of lymphatic massage. We've got to keep it out with the compression, and that's the biggest thing I educate on because, it's June now, it's warm out, so you add an extra layer on your arm, and nobody loves that if they're going to the beach. But that's the biggest thing I really stress, because sometimes people want to take a little holiday from their compression sleeve, and that's never a great idea. Because if you go on vacation for a week and you keep that compression off for a week, when you come back, it's going to be awfully hard to get that compression sleeve back on. But everybody needs to go on vacation, needs to go to the beach and the pool. So I always say, let's think of a strategy before you go. If you're obviously not going to wear that sleeve in the swimming pool. So if you're going to be down at the pool for 2 hours, make sure you have that sleeve on all the way till you're getting in the pool. And then when you leave that pool, get it right back on. Or if you're going to a wedding and you're wearing a strapless dress and you don't want that sleeve on, you know what, maybe we'll take it off for a couple hours just during that time, but you can't have it off all day, or you're going to be starting over a lot. So I think just when patients understand that, you can't take a break from it when we're in that treatment phase, you've got to keep that on most of the time. I think that really helps the understanding. You talked, Dr. Tiwari, about the importance of exercise. It was really back in 2009 when they did the first studies looking at lymphedema and exercise. Prior to that, they really recommended people not do a whole lot with those extremities. And in 2009, they did a huge study. It was called the PAL trial. It's called Physical Activity and Lymphedema. And that was overwhelmingly showed the importance of exercise, and not just any exercise, but a really dosed exercise where you started out low and progressed slow. That's Catherine Schmidt is the person who did that study, and that was her mantra all the way through the study was start low and progress slow, and that way when your body comes across a stressor, it's ready for it. If you're not doing anything with your arms and all of a sudden you've got to pull a heavy suitcase, then that's a big stressor which could overload that lymphatic system. But if you're working out pretty regularly, maybe every other day, 2 days a week, maybe 3 days a week with a 48-hour break in between, that keeps those muscles ready so that when you have those stressor events, which we all have, maybe you decide to put Christmas decorations up for 4 hours overhead. That could be a stressor. Or, you do something a little out of the ordinary. You decide I'm going to garden for 4 hours today and you hadn't done it all winter. When your body's ready for that, you're not going to see that lymphatic overload. So that was a great study. I always encourage anybody to look that study up because it was just really overwhelmingly showed the benefit of exercise, not only in people with lymphedema, but those at risk. So it really showed benefit for both. So really interesting study.
That's such great information. I do have a question for you, Jodi. Patients usually ask us, can I get blood pressure on the arm that had to send a lymph node biopsy? What do you tell them?
Yeah, that it's interesting you bring that up because when I did our Revital training, all of our clinicians go through 6 months of oncology training, and when I went through it, they have done some research that sort of debunked that. They used to always say, don't get your blood pressure, don't get an IV, don't get anything done on that, and they really couldn't find any hard and fast research that showed that that was true. But still, most people say, if there's a choice, let's do the other side. If it's an emergency situation, do whatever you need to. But if there's a choice, I always tell them, do it on the other side. But the research truly has not shown that it will cause it. But I tell my patients, if you have a choice, point the person to the other side, the non-at-risk side.
So one thing I'd like to touch on is scar management, Jodi. How do you folks deal with areas where people feel tight, they feel restricted, maybe it's causing a bit of a contracture? How do you manage that?
Yeah, when patients are usually about 6 to 8 weeks out, we want to make sure that scar is completely healed. No, not even the tiniest little minuscule scabs. We want all of that gone. That's when we'll start some scar massage. And, if a scar goes one direction, we typically are massaging perpendicular to that scar. And what I tell patients is it's not that there's anything wrong under the scar, but when you reach, you're going to feel some restriction there if we don't break that up a little bit. So I usually will instruct patients how to do it and have them really only do it for 1 or 2 minutes a day. It's not something you're spending an hour on. You might spend a couple minutes in the shower in the morning, maybe a couple minutes, in the shower in the evening, and that's going to be enough to start stretching it out. And I instruct patients I'll do it and then I'll have them do it. And we'll kind of go back and forth so they really understand how much pressure should I give, how long should I do this? What part of my fingers and hands should I use for that? But that can be useful. Not everybody needs it, but a lot of people need at least a little bit of it, especially if it's a big incision. If it's a smaller incision, like a lumpectomy or partial mastectomy, we don't always need that quite as much. But certainly the sentinel lymph node biopsies, that's an area that sometimes will scar down a little bit underneath. And it just doesn't feel good when you're doing that full reach behind you. Then all of a sudden you're feeling that restriction there. And, I want people to be able to move freely without that feeling of, am I going to hurt something here?
This is all really great information, Jodi. Thank you so much. When patients get told you have breast cancer, you lose control. And to know that there's things you can do to get your new normal back or to get the quality of life. It's all about quality of life. And Dr. Tiwari and I, that's our goal with our podcast, is to help our listeners to improve their quality of life and also to empower them. And this has been a great podcast talking about the control you can take back with exercising, with lifting weights, and being consistent, I think, is your message. Am I right in all that?
Yeah, absolutely. I think, don't be afraid to reach out for help. I think from the moment diagnosis, there's a lot that happens quickly and people get a bit overwhelmed and, they go into offices and they forget to say, but I haven't been able to go back to work or I can't lift my child yet. So it's the number one thing I tell patients is, talk to your doctors. They want to know when you're having difficulties at home. They want to know that because there's help. There's things that we can do together. And, therapy is a positive, fun environment. It's a serious topic we're talking about when they come in. But once we're there a couple of times, we have fun out in the gym. And there's patients all around them that are working on the same things. And it's a bit of a sense of community. And it's something that a patient can take back control of. If you're having, say, arthralgias from being on aromatase inhibitors, if you know what to do when that happens, it gives you back the power of, okay, I know how to manage this symptom now. Because as a physical therapist, there's things that patients are going to depend on me for, but my ultimate goal is to make a patient independent so that when they have symptoms come up, they know how to handle it and they know what to do. And they know when to call me. I always give patients my card with my email and phone number on there and say, you're graduated now, but you're still my patient. So if you have a question in 2 weeks, just email me, call me. Don't ever think you're going to bother me. I want to know when you have those questions, as I'm sure you guys do as well. I don't want anybody ever to suffer at home and say, I guess this is just the best it's going to get, because it's not. I want everybody to be able to do, the things they love and live the best life that they can.
I think that's a wonderful message, Jodi. Thank you so much for spending some time educating us and our patients. And where can folks find you
Absolutely.
if they need to talk to you?
Yeah, absolutely. Well, I'm a part of the Revital team. So we have a website, revitalcancerrehab.com, which we have here in Columbus and in a lot of cities around the United States. Even if you're in a city where you don't have it, if you get on that website, it'll show you where the closest therapist is. I myself treat in Westerville at our State Street office, and we have clinicians all over the city. We've got 45 clinicians that are Revital certified here in Columbus, so that's an important thing to see a clinician that really understands oncology rehab. Most physical therapists don't get much oncology training when they're in school, so it's important to see someone that has that extra training, that has a relationship with the physicians you're working with, so that you can all work together as a team and make sure that everybody understands what's being done.
Yeah, that is really great that you offer information on your website for people who are outside of Columbus. I'm glad you brought that up. So your information will be on our podcast, be listed there, so our listeners can go back and find it there as well. So thank you so much for giving up your time to be here, and thank you for educating us. We really appreciate it.
Oh, thank you. It was fun.